Hello, everyone, and welcome to this audio podcast. This audio podcast is part of this, as part of a Labostix Monstrosity, as part of the Labostix Monstrosity Intermission. This is an audio podcast aligned to a Shientific syndrome. This is an audio podcast as part of another Storm Labostix production. So in this sort of Labostix Monstrosity sort of intermission, there'll be an overview in around some works that have been peer reviewed and published in around 2019, and looking at sort of the looking at sort of initial findings, really, initial findings in around some works, some collaborative works looking at sort of physical activity, energy, nutrition, and understanding laboratory parameters in around chronic kidney disease, or CKD, and wherein this works was sort of pilot findings or initial findings following an educational webinar that following sort of an educational sort of webinar, or a series of webinars that took place through sort of a collaborative sort of platform, a collaborative platform, and wherein the collaboration this collaboration was between the social media platform, the RPSG, the Renal Patient Support Group, the RPSG, and there was several collaborators across different organizations representing sort of efforts in the United States, and so this works was peer reviewed and published in the Journal of Clinical Nephrology and Kidney Diseases, again in around 2019, and in social media, part of the descriptive in around social media, or on social media, there will be a sort of an overview where listeners who are checking out this particular audio podcast intermission in around this Labostix Monstrosity can check out the sort of the overview, or the sort of the sort of abstract, the sort of abstract, if you like, in around this works on social media. So this works to begin with. So physical activity has been known to produce various advantages, physiological and psychologically, in around those who suffer with chronic kidney disease. Those who suffer with chronic kidney disease, for example, post-transplantation, although there are initial potential phases where physiologically, for example, the allograft is adapting to sort of what is referred to as immunological tolerance. Overall, the advantages of sort of physical activity include, for example, prevention of various sort of comorbidities, increases in heart rate, or cardiovascular activity in a positive sense, and also reducing, for example, or preventing sort of edema or pitting, for example, in the ankles, especially wherein, for example, in recipients, irrespective of pre or post transplant, where edema or pitting around the ankles can be can be a sort of sort of a sort of a side a sort of a side effect, so to mention, the pitting and or the edema type symptomology becomes reduced, owing to the physiological basis in around physical activity. At the same time, physical activity prompts a more productive, a more productive transplant organ, to also help increase heart rate, and also physical activity reduces, for example, as per mentioned in aspects around psychology, for example, sort of things like around stress, frustration, anxieties, and links to what has been in evidenced in the literature, in around, for example, for example, depression, where there's lots of where I'm sure listeners will know there's lots of literature evidence in around aspects of depression. At the same time, physical activity increases what is referred to as beta endorphin in context of endocrinology, and causing a state of or a basis in a sense of euphoria, or feeling good, feeling well about oneself, for example. And also physical activity in literature has been referred to and documented as a potential sort of coping strategy. And this also now means that against symptomologies around chronic kidney disease, or CKD. This means that those who suffer, irrespective, again, pre or post transplantation, should be encouraged in whatever ways, in whatever possible advantages, to keep to be and keep sort of proactive. Now, at the same time, CKD recipients or patients, or service users, for example, must be careful to some extent with physical activity, at least in early phases post-transplant, because of the potential changes in for example, the biomarker that is used to detect, or used to determine renal function, and that of being creatinine, and other important laboratory parameters, because the transplant or those who are transplanted, because those who are transplanted in the early phases in context of the immunology and the immune response and immunological tolerance in around the immune system is something that is initially foreign between recipients histology being tissue in context of physiology, tissue physiology, and also in context of general physiology, because a foreign organ transplanted into into the body, for example, initially is of foreign basis, and at the same time, it is It is at this time where a transplanted organ or an allograft was referred to in medical texts, in immunobiological texts, and also in sort of in around transplantation literature is referred to allograft, where allograft in the early phases is is referred to as a vulnerable point, and should not be should not be should not be compromised, so to speak, owing to certain aspects of the immune system that can prompt a sense of chemotaxis that prompt chemokine and cytokine infiltration towards the allograft, causing either AMR, which is referred to as acute form of transplant rejection, AMR, or hyperacute rejection, which becomes actually more obvious very early. For example, if the transplant if an organ that is transplanted in the early phases, we're talking perhaps between the first 20 to 30 minutes post-transplant. As soon as the organ is transplanted, hyperacute rejection occurs in almost immediately, and the organ and the sort of surrounding area in context of anatomy actually becomes sort of a bluish color. So thus the transplant is quickly realized that there's rejection at that point. However, these sort of terminologies are important, and at the same time, several investigations have evaluated sort of physical activity in around the CKD population in specific sort of literature to inform physical activity results, sort of improve a sense of performance and health in recipients with particular forms of CKD. Several investigations and studies also inform that risk factors, including hypertrophy and oxidative pressure, could improve with physical activity in this particular disease disease focused population. At the same time, intriguingly, there have been little or no investigations that have reported worsening of kidney function or renal function as a result of physical activity. Physical activity appears to be safe. In this population, if, for example, if initiated mild to moderately at moderate intensity, for example, and increased gradually. Now, the evidence also suggests that the risk of remaining for example, inactive versus proactive can cause a symptom of more detrimental symptomology. One particular review has summarized or has highlighted quite intriguingly that end-stage renal disease, or ESRD, physical activity and the elucidation of its effects on biomedical and hematological parameters in around the hemodialysis as a form of renal replacement therapy patient population or recipient population. And there will be a sort of another Labostix Monstrosity sort of intermission that will focus on this in sort of prospectively. However, the aim of this in around this particular overview is to also highlight, in addition to providing some basic background in around laboratory markers or laboratory parameters or laboratory markers, because let's be honest here, we there are health professionals. There's health professionals who have trained for many years around different aspects of laboratory tests and investigations, and then there are those who for example, who have some knowledge, or have some basis in around particular intriguing physiological markers and context of nutrition or nutrition health. However, there's very little little understanding in around the actual pertinent aspects around the disease focused population, and in context of physiology. Hence why in industry, in around different industries, dare I say, there's always a sense of promotion in around different kinds of nutrition, for example, in around different aspects of nutrition. For example, with those who partake in particular aspects of sports, for example, or partake in particular sort of physical aspects of physical activity. There's a sense of promotion around different nutritional forms of health, nutritional aspects of health, and at the same time, there's also unfortunately a lot of hoarding of understanding or wealth in context of how others in the general population can gain an advantage around that. So before getting into aspects of nutrition, and by the way, there will be no aspects in around nutrition or aspects in around this particular audio podcast, mainly focus on this audio podcast and the prospective audio podcast in this particular around this Labostix Monstrosity will primarily focus on the laboratory parameters, because it is the laboratory parameters that actually are important, when actually determining between health, between abnormality or abnormal etiology, and actual between abnormal etiology and disease. Abnormal etiology and disease against normal and healthy sort of physiology. And so this work will look to highlight what sort of biochemical parameters are affected throughout physical activity in around this patient, in around sort of this population, and also will look to provide a sort of baseline data or initial findings of collaborative webinars summarizing in around sort of energy, looking at sort of aspects around energy and physical activity. So to begin with, a little bit around clinical chemistry parameters and what are important. So the main one being creatinine, and I don't mean, as I say creatinine, notice how I say creatinine. I don't mean creatine. I mean creatinine, which is different. And so in transplanted patients, transplanted patients, or those who have been allografted, tend to be sort of, at least in the initial phases after serious intense surgical procedures, sort of detrimenting normal physiology. For example, the initial phases is where recipients can be anxious, for example, around creatinine and the creatinine parameter. owing to the risk of developing what is referred to as acute allograft rejection, or AAR. Now, the psychological implications of this are yet to be are yet to be in some regard to be investigated in some depth, in around some depth. However, creatinine is significantly different. Can be significantly different post-transplanted when compared to the hemodialysis or those on forms of renal replacement therapy, simply because, as with normal renal function, or normal kidney function, I should say, a renal allograft can process up to 180 liters of blood daily, whereas a recipient, or those in this population, on a form of RRT, or renal replacement therapy, even at sort of maximum adequacy, will only unfortunately, owing to anemia, and we'll get into aspects of hematological parameters a little bit later, but basically, owing to the symptomology, one of the main symptomology in around renal or kidney, in around kidneys, is the symptomology of anemia, or being a sense of anemic. And now, in the renal replacement therapy population, even at maximum, potentially at maximum, and undergoing forms of undergoing renal replacement therapy, at maximum, the kidneys, or sorry, the artificial kidney, or what is referred to again as the renal replacement therapy, at maximum, even with different parameters set high in context of renal replacement therapy, the maximum turnover in context of blood volume being turned over, to prevent a sense of anemia, but also to bring a sense of homeostasis into general physiology, then basically, the kidney, in context of renal replacement therapy, the maximum that the blood that recipients can turn over on a form of renal replacement therapy, with the different aspects of parameters being increased, would be potentially around about 100 liters of blood, over, for example, over 4 hours, 4 hours or 5 hours, 4.5 or 5 hours of treatment, at maximum 3 times a week. For example, whereas typically in normal renal function, it's about 180 liters of blood a day, that the kidneys can turn over. So this is important. It's important to get a differentiation, because there are those who claim to be experts in around aspects of physiology, not actually understanding anything to do with renal function or kidney function, and when, for example, highlighting aspects about promoting particular nutrition or nutritional health, when nutrition health or particular nutrition can detriment kidney function at the same time. So in around this, um, so at the same time, for CKD patients, or those who are in this sort of population, who for example, are prompted or propagated to be or propagated as active, and enjoy sort of being proactive in around physical activity. The immediate post-transplant phase versus the pre-transplant phase, for example, can be frustrating, or is frustrating, because of what's referred to as the abnormal sort of blips that partake, or that partake in around the creatinine, but also in around, for example. So I mentioned a little bit about how nutrition can cause certain kinds of nutrition can in some regard cause detriment to different other parameters that are linked to creatinine. So one particular parameter that's linked to creatinine, and again not creatine, creatinine. Another parameter is what is referred to as urea. Now, urea, as everyone, I'm sure, our listeners would know, is a byproduct of a byproduct in around waste. Primarily the byproduct of muscle of what's referred to as muscle breakdown is creatinine. Then from creatinine you get urea. Urea is that strong sort of sense of smell, which actually is linked to either where for example particular diets, for example. And again, this audio podcast will not delve into aspects of the diet, the sort of diet or nutrition. That's not the basis. Mainly around the sort of laboratory biomarkers, the laboratory markers. Now, basically, in around urea, in certain aspects of food types or nutrition in some regard have automatically have high urea. For example, red meat, for example, would have a high urea, and thus can impose or implicate renal function as well, sort of automatically. Now, at the same time, where there's these sort of abnormal blips in creatinine, urea. There can be these abnormal blips, in around creatinine, urea, and even in what's referred to as immunosuppression dosing or trough levels. Now, although post-transplanted recipients or patients can participate and should participate in physical activity in the immediate phase post-transplant, in the immediate phase post-transplant, for example, this activity initial phases sort of post-transplant should be where physical activity should be quite light, so that the transplant the allograft and the cardiovascular system can adapt, and then that way creatinine is still at the same time in all cases, creatinine sort of retrospectively is still one of the best or routine sort of investigations for monitoring renal function. And again, it is a byproduct of muscle breakdown and ultimately excreted by the kidneys. It can be higher in muscular people. That being said, creatinine clearance is a challenging sort of parameter or laboratory parameter for renal for those who are detrimented by renal abnormality, but it is helpful and especially useful, particularly in the first 24 hours post-transplant, for example, and where physicians and laboratory specialists, for example, can require and request, for example, 24-hour urine collections to actually 24-hour midstream urine samples to understand whether there is any deficits in the urine in the initial phases post allograft sort of transplantation. Now, in around urea as a marker as well, So urea is a small protein. It's a small protein-based chemical that is excreted by the kidneys in normal renal function. Urea levels and urea levels increase sort of irrespectively, but when a renal function when and mainly when renal function declines. So as creatinine increases, when creatinine can increase, where there's a detriment to renal symptomology, there can also be an increase in urea levels. Now, I want to sort of highlight these. I want to highlight the fact that again, there are those who claim to be nutritional experts and not actually factoring in the renal aspect of the nutritional basis around what they are promoting or what they could be promoting. So, for example, if there are sort of those sort of nutritional or those supplementary aspect or supplements, for example, experts or claimed experts are promoting without factoring in the renal aspects or the renal the renal organs or the kidneys or the renal function in around what they're promoting, then generally it's a problem. It's a problem. It's a problem in around nutrition and the way nutrition is being promoted, if for example it is not factoring in renal function. So it is at the same time in around urea, where urea can increase if creatinine is increased, and then thus leading into a form of CKD or chronic kidney disease, a chronic kidney disease or CKD. At the same time, urea is synthesized by what is referred to as the urea cycle reactions, by urea cycle reactions of a carbamoyl, phosphate, and ammonium, which are derived from deamination reactions, and it is not such an accurate urea on its own is not an accurate sort of it's not an accurate sort of function in around the kidneys on its own, but it is useful when it's used in conjunction or in aligned to and linked with creatinine, because it is affected again by muscle breakdown and how much protein how much protein, for example, is consumed, and whether for example patients or those in the amongst the public have consume for example enough consume sort of high protein based food, high protein based sort of nutrition, etc. Now, at the same time, if that is the case, and as this peer review publication sort of indicates or informs, that with high urea or high urea foods or high urea type nutrition, there should be more fluid consumption in context around this, so thus in context of physiology, in context of general physiology or general symptomology around physiology, that there is general hydration. There is general hydration in around physiology, and thus the kidneys or around the renal function. There's a sense of that. Sense of a prevention, a sort of a prevention of dehydration, wherein the kidneys, as everyone is perhaps aware, that the kidneys by default are actually referred to, and perhaps the only organs in human physiology are referred to as wet organs. Naturally, they are wet organs, and they have to stay wet. They should have to stay wet, because dehydrated kidneys then thus leads into what's referred to AKI, or acute kidney injury. Now, another important parameter, more linked to cardiovascular more so than renal, although very important in around renal and kidneys, is a parameter known as potassium. So potassium is a mineral important for fluid balance in the body, and for normal functioning of the cardiovascular system, kidneys and other organs function as well. Now, potassium is found primarily in various forms of nutrition, and at the same time, too much potassium can be harmful, especially those who have especially those who may fall into renal insufficiency, or those taking specific drugs or medications to treat other particular symptomologies and comorbidities. Potassium, at the same time, in the nervous system is critical. Is critical, important, to maintaining normal electrical rhythm and normal electrical signals as well. Now, in this works, when this works was sort of published, the normal potassium level in around the blood was 3.5 MEQ per liter to around 5 MEQ per liter. The parameters in the laboratory parameters, or the ranges actually may differ from different laboratories, and so it's important for anyone who's intrigued to find out what the normal reference range, what the normal sort of potassium sort of reference ranges are, and thus preventing going into hyperkalemia, which is where potassium levels above 5 or above, between 5 and 6 MEQ per liter, or above 6 is where there can be symptomologies leading into sort of arrhythmia. Now, another important parameter is calcium. Now, total and free calcium concentration is characterized by a high physiological variation, and depending on age, gender, physiological condition, for example, women or females in pregnancy, and even seasonal variation due to seasonal variation of vitamin D, for example, which is directly involved in calcium concentration regulation. And calcium is ultimately important for general contraction throughout physiology. Now, I mentioned sort of in the earlier parts of this audio podcast a little bit about that I would delve into some aspects around hematological parameters, and so here's some bases in around the hematological parameters. So in CKD, or in the chronic kidney disease population, but also important in general physiology, general population, serum iron transferrin, and the iron building volume, saturation, and ferritin are generally normal. The non-heme iron absorption from the intestine is also abnormal. Is also normal, as highlighted in iron kinetic studies. It was suggested that a decoupling between the endocrine and the excretory function of the kidney is more responsible than its inability to produce erythropoietin. Erythropoietin, by the way, I'm sure some will be aware, if not everyone, those listening, those listeners who are checking in on this audio podcast, erythropoietin is a hormone is primarily is primarily a basis in around where the kidneys or the renal functions stimulate erythropoietin to stimulate erythropoietin to actually prompt and propagate the stimulation of red cells, or red blood cells. Now, at the same time, the endocrine and its excretory function of the kidney or renal function is more responsible than its ability to produce erythropoietin. However, given the increased levels that can occur in CKD patients with anemia, with acute anemia or hypoxia or hypoxic or hypoxia, and so erythropoietin or EPO, as it is abbreviated as such as, is important in general as a general parameter in a right that links as a hematological parameter, but also in around endocrinology as well. Now, the improvement of anemia after different forms of renal replacement therapy, for example, was actually first described in the 1970s, resulting in the presence of uremic and erythropoiesis inhibitors in the plasma. Polar lipids, arsenic and spermidine, vitamin A, and the parathyroid hormone are also substances or components suggested that are important as uremic as sort of implicators in around the symptomologies around uremia, and can cause a sort of an inhibition in around the uremic process as well. An overload of aluminium in renal replacement therapy, in those undertaking renal replacement therapy, is also suggested to cause microcytic anemia, possibly by inhibiting the erythroid marrow as a result of transferrin binding. So transferrin is an important component to prompt a sense of iron being sort of linked into linked to oxygen in the blood, and thus allowing sort of oxygen saturation throughout physiology, in sort of normal physiology. So transferrin binding is important as part of that process. Now, each dialysis procedure, and this is important here as well, for those who are on forms of renal replacement therapy, different forms of renal replacement therapy, each dialysis procedure or each form of renal replacement therapy in context of dialysis involves a certain amount of blood loss, which amounts to in around, for example, anything around 4 mil to 20 mil, with an additional loss resulting in frequent blood sampling or venopuncture. A patient, a recipient on a form of renal replacement therapy may lose more than 2 milligrams, may lose something in the region, something on the basis around 2 milligrams of iron per day. In addition, chronic infection and inflammation also play an important role in the anemic or the anemia pathogenesis. Now, a study has identified apparent microcytic hyperchromic anemia. So that's so microcytic is where the red cells, they are smaller under microscopy or morphology, and where hyperchromic is where is where there's a tinge, there's a sort of a tinge to the red cell, almost like a silvery tinge or a brown or sort of a brownish tinge over the red cells, and where in context of morphology or anemia, or in context of morphology, anemia is then determined in forms of renal replacement therapy. And another study, another investigation had revealed normocytic or normochromic anemia in around 81%, of those on renal replacement therapies or forms of renal replacement therapies, in particular and specifically hemodialysis. Now, the uremic bleeding pathogenesis is important, but is important, but it is not completely understood. And so there have been no sort of major sort of changes in plasma, or no identifiable sort of major changes in plasma coagulation factors and fibrinolytic system. That does not mean a fibrinolytic system, which does not automatically mean at the same time that within physiology, in those in renal undergoing forms of renal replacement therapy, or forms of renal replacement therapy, that automatically that they are that their physiology is impaired, although owing to the anemic basis, the reverse can automatically be conveyed as true. Now, another important sort of symptomologies in context of hematological parameters that are important include ecchymosis, purpura, epistaxis, and bleeding from venipuncture sites, which are common hematological manifestations in around general physiology, but also again linked to uremia, linked to aspects around uremia, and general anemia. There are also symptoms, or there can be symptomologies around cardiac tamponade after pericarditis and pleural effusion. Because remember, if we look at if so I by so prompting it as sort of an example on this basis, if you think about those on forms of renal replacement therapy, and particularly those for example, on peritoneal dialysis or PD, or hemodialysis or HD, for example, as forms of renal replacement therapy, they're quite distinctively, or almost quite distinctively, they have they if they on these forms of renal replacement therapy, as they go under these forms of renal replacement therapy, pericarditis, and pleural effusion can be semi obvious, owing to the biochemistry and biochemical parameters being abnormally constrained. And a major complication, one of the major complications, is that spontaneous subcapsular hematoma of the liver can occur as well, as in the case also as subdural hematomas as well. Uremic bleeding has also been attributed to a quantitative platelet reduction. As everyone, I'm sure, any listeners out there will know that platelets are important for clotting basis, on a clotting basis. And so uremic bleeding has also been attributed to a sort of platelet reduction in anything between 20% to 52% of particular cases in the literature. Now, at the same time, the exact mechanism behind the elevated behind what's referred to as a particular investigation that's used in laboratories known as the erythrocyte sedimentation rate. The exact mechanism behind an elevation in around the erythrocyte sedimentation rate is not in those who are confirmed as ESRD patients or recipients or end-stage renal disease. It's not directly linear, and the hematology generally in end-stage renal disease or service those who are service users as end-stage renal disease patients can be sort of identified in the literature. So I want to delve into a little bit now, around the erythropoiesis aspect. So erythropoiesis in CKD, amongst patients or recipients with CKD, there can be relative deficiency in erythropoietin production, and this is in the main is because of the anemia. Now, other factors that may contribute include iron deficiency, blood loss, inflammation, hemolysis, and also particular nutritional deficits. However, the central role of erythropoietin deficiency is well documented and best demonstrated by the consistent and robust improvement in particular in around hemoglobin concentrations after treatment, after forms of renal replacement therapy treatment with particular forms of treatment, for example, recombinant human erythropoietin, and surprisingly, serum erythropoietin concentration is often not reduced in CKD, except in relation or in regard to where there's a parallel between the severity around CKD or form of chronic kidney disease and where anemia is part of the is with the symptomology. However, as CKD progresses, erythropoietin deficiency becomes more pronounced, and the decline of serum concentration parallels kidney excretory functional loss as well. Now, in the peer-reviewed publication, and there will be a citation on social media around this works as part of this Labostix Monstrosity sort of audio podcast intermission. There is some works in around some aspects in around sort of nephrotoxicity, polypharmacy, and looking at sort of different different aspects of polypharmacy. However, now delving into the aspect of why is physical activity important, and wherein physical activity in line with immunology as immunology, and not so much the aspect around psychology or neuro or in around or in around the neurosciences, but more around owing to a link between physical activity in line with immunology. Now, one review sort of retrospectively considers 6 aspects of recovery and rehabilitation. For example, one of those, at least one of the sort of aspects had been linked to sort of functional recovery but also where particular works had highlighted that while studies have become sort of more ambitious and rigorous, there is sort of a need or requirement to move from to link sort of multidisciplinary interventional investigations with those who might suffer with forms of renal detriment in around renal detriment, and where physical activity can increase the number of, for example, can increase number of circulating lymphocytes and lymphocyte subsets, including natural killer cells or NK cells, followed by decreases in and cell counts during recovery from physical activity. And this lymphocytopenia as well, where lymphocytopenia is where there's a drop in white T cells, or particular T cells that can cause detriment. That at the same time can be advantageous in some regard, but at the same time a low lymphocyte count can also be problematic. Can also be problematic. So this lymphocytopenia or low lymphocyte count appears to be owing to a decrease in percentage of type 1 T cells and NK cell circulation at the same time. T cell proliferation and T cell production, for example, in interleukin 2. I mentioned interleukin 2 or IL-2 because IL-2 is very important in those who for example may in around renal pathophysiology, where interleukin 2 is one of the main sort of immunological subsets which are in literature has a lot of basis and importance around, alongside interferon gamma, and is immediately reported after as an increase. Can increase after acute and intense forms of physical activity, and after physical activity, after physical activity, NK cell activity or NKCA per cell does not appear to alter unless the amount of prolonged unless the bout of sort of particular forms of physical activity becomes stressful, because again it is important to appreciate that in forms of physical activity, whilst there can be a sense of enjoyment, after a certain point that the physiology or the pathophysiology can become detrimented or stressed, in which case NKCA or natural killer cell activity can also stay depressed or suppressed for several hours, and resting immune function in particular is not very different. Is not very different. Is not very different between, for example, those who partake in physical activity on a day-to-day versus those who are not, for example, are not in the same basis. However, intensified training periods in already well trained sort of around a range of well trained individuals, for example, can lead to immunity depression or suppression at resting on a resting basis in context the immunological components or the immunological basis. The cumulative effects of repeated seizures of intense physical activity result in increased stress hormones as well, particularly cortisol and anti-inflammatory cytokines. So, for example, interleukin 6 and interleukin 10. This causes a temporary blockage or blockade of type 1 T cell cytokine with a relative dampening of type 1 cell mediated responses as well. So in around sort of the cytokines, in around the cytokines, one team had demonstrated that physical activity leads to a reduction of a percentage of type 1 T cells, and one team investigate the mechanisms underlying the physical activity induced shift in the balance between type 1 and type 2 cytokine producing cells. In this particular works, seven healthy males were performed a 1.5 hour of treadmill running with blood samples drawn before physical activity and at the end of physical activity, and 2 hour post physical activity. Intracellular migration of interferon gamma, interleukin 2 and interleukin 4 were detected in CD4 positive and CD8 positive T cells after stimulation with particular treatments such as 4-ball 12 mystery and 13 acetate and enomycin. And during post physical activity during post-physical activity, intracellular expression of interferon gamma within CD8 positive cells were reduced compared to values obtained immediately after physical activities, whereas the expression of interleukin 2 and interleukin 4 did not change within the CD4 and CD8 positive cell populations. The decrease in interferon gamma producing CD8 positive T cells post physical activity has been negatively correlated with a decrease in memory percentage T cells within CD8 within the CD8 positive cells. The study, the team that carried out this particular study had identified that physical activity induced change in type 1 cytokine producing T cells, and it related to a decline in memory cells, in particular memory cells as well. So in around the paper, the peer review paper has some more aspects in around the sort of physical activity and cytokines, and also the aspects in around T lymphocytes, and also aspects around some bases in around sort of physical activity and particular aspects of endocrinology. So, for example, looking at epinephrine, norepinephrine, cortisol, and also looking at works around sort of particular sort of T cells and lymphocyte subpopulation changes and percentages in looking at percentages in around that as well. But however, I'm now going to delve into sort of the collaborative aspects around this, and looking at for example the collaborative webinar that took place around this. So having identified where CKD recipients would find it most advantageous, the research team or the collaborators in around this work had several online communications to highlight what physical activity and aspects of nutrition, for example, understanding could or would be advantageous to to those in the in around the CKD or RRT population and prompting a sort of an open webinar at the time. It was decided between the team. It was decided between the team to implement an educational webinar through the Renal Patient Support Group, the RPSG, and at the time the RPSG had around 8,000 service users internationally. The team decided to develop a webinar delivery generic to real life. To aspects of real life, and to provide best practice so that CKD service users would gain sort of gain most advantage. And the webinar was planned in around about 30 minutes plus 15 plus or minus 15 minutes for potential Q&As. Accordingly, and the team also seek to obtain an understanding of main questions that may be prompted from the RPSG in the main from RPSG sort of service users across in around a particular social media in around the social media platform. So in around this works, at the same time, there was a consideration for the need for ethics approval was made, and the Department of Health Guidance was consulted at the time, and a consent for a collaborative webinar data was provided by the RPSG administrators, and taken further consideration in around the General Data Protection Regulation GDPR 2018, and in keeping with this, the team had also ensured that there would not be any reporting of personal identifiable data or PID. So, for example, names, dates of birth, addresses, and or locations of participants. And so in around this, the basis around this was then that the time frame for attending attending the online webinar was again limited to 30 minute only, and therefore a sample size calculation was not carried out. Instead, a target sample of around 1,000 was set in context of those who would attend who would look to attend the online webinar. And it was important to get a representation from various ethnicities using the RPSG at the time, and the webinar details was pinned at the top of the social media platform over the planned time. So it was in around the results around this works then. So in around December 2018, the RPSG and collaborators formally introduced a wellness sort of a webinar. A wellness sort of webinar to the RPSG membership through this closed social media platform, and 1,000 RPSG members had actually had attended the online webinar, and at the time representing in around a 14% response rate. Being an international support group, the respondents had demographics with varying ethnicities, age range, and gender representation. The research team did not seek to gain any personal identifiable data or PID. Some main questions from those who attended the webinar included: number one, what are some of the good healthy sort of foods can be taken for can be consumed for those on forms of renal replacement therapy, for example, hemodialysis. Number two, what are some of the possible physical activities that can help manage, for example, back pain? Number three, how can patients or recipients in the CKD population who have been on dialysis on forms of renal replacement therapy for over several years sort of reassess and do better to keep motivated. And the team informed it is important to it is that it was during the time of this works, the team had informed it's important to for recipients of people those in the CKD or renal replacement therapy population to keep an eye on various aspects of physiology and pathophysiology, and it's also important to keep important to reset and sort of aspects around life since different forms of renal replacement therapies can sort of negatively implicate aspects of well-being, wellness and well-being. And in addition, in addition to this, the colleagues and collaborators in around this works had highlighted that there's little evidence that highlights how webinars and online learning supports patients in around CKD, and information providing this webinar was well intended, and at the time it was the first sort of webinar of its kind. It was anticipated that our subsequent RPSG collaborative webinars would involve more health professionals, for example, cross disciplinary or cross specialty, to support CKD patients in a range of health focuses. So in around sort of the sort of summary aspects of this works. In order to so for example, the peer review publications also sort of lists quite nicely the summary of the literature, where the summary of the literature sort of compares and contrasts different author works, peer reviewed works against different sort of sample and populations, looking at the main findings and looking at some themes that the peer review works are linked with. So, for example, physical activity and polypharmacy, physical activity and immunology, physical activity and looking at endocrinology as well, and so in around the sort of implications implications to practice in context around this. So there are several reasons for recommending sort of physical activity, including a restoration of physical functioning following deconditioning of following deconditioning of a particular pathophysiology and general human physiology. Number two, the majority of CKD patients have been documented, or at least in some aspects of the literature are unfortunately defaulted as an inactive as an inactive population. And number three, the high prevalence of particular comorbidities that may be modified by may be modified by regular by sort of physical activity. And number four, physical activity can optimize again physical functioning between pre and post transplant sort of bases. And at the same time, other factors to prompt physical activity in CKD recipients or patients are perhaps more obvious, including for example, for example, where the from an immunobiology basis, there is a sense of tolerance as well, where physical activity can prompt a sense in around that. And also, to optimize overall health in this particular population, routine sort of physical activity can be prompted and encouraged as part of care. And practice and research also need to consider how such education how such sort of education in and around aspects around this is propagated. And sort of research should research in around sort of this works in around this works, and also should consider information providing surrounding again in around sort of the sort of laboratory parameters, and also for example, wherein patients, especially wherein patients or recipients within the CKD population, can can often have sort of can often have questions in around gaining an understanding or wanting an understanding about what they should or should not do. And future practice and research should also identify sort of again sort of cross collaborations between different specialties as well. So in conclusion, there is a range of literature that relates or regards sort of physical activity entity with stress and T cell sort of in around T cells in context of immunology or immunobiology. And although some investigations may not directly relate may not be directly related to transplantation, compelling evidence also shows that physical activity reduces particular T cell components in around particularly in around CD8 and CD4 in particular forms of physical activity. And there are some there should be more sort of collaborations amongst disciplines and specialties, so that's to enhance practice aspects around aspects in around practice beyond sort of the clinical environs. And a call for more sort of again more multidisciplinary collaborations. And studies are also required on understanding sort of pathophysiology of creatinine, urea, and protein and aspects of protein early in around the between pre and post transplant phases. And this could also be accompanied by investigating physical activity physiology, particularly elaborating on around lymphocyte or leukocyte trafficking and acute allograft rejection. So at the same time, and sort of finally, really, that that webinars could become more important as part of joined up sort of healthcare sort of prospectively. So that draws this audio podcast around this sort of intermission in around this audio podcast intermission around this Labostix monstrosity, this Shientific syndrome audio podcast, and this sort of Storm Labostix production to a closed online. As part of this online on social media, there will be some citations where listeners out there can identify sort of the citations around this works, but also around sort of similar works for referral. So thank you for tuning in, and thank you for tuning in, and hopefully this has been useful.